Peggy Gunter from Aspen, and video 2 of our commercial blended tube feeding series is the use of commercial blended tube feeding products in the hospitalized patient.
My name is Catherine Bennett, and I'm a registered dietitian at Chalk Children's Hospital, part of Rady Children's Health. Over the next several minutes, we will be reviewing indications for commercial blended tube feeding in the hospitalized patient. Let's start with defining commercial blended tube feeding products. Commercial blended tube feeding products are ready-to-use tube feeding formulas made from real whole foods that are blended to a smooth consistency for delivery via a feeding tube and can be used as a convenient alternative to prepared blenderized tube feeding. Commercial blended tube feeding products must contain real whole food ingredients. Commercial blended tube feeding products may either be animal or plant-based. It is important to note that just because a product is plant-based doesn't mean it contains real whole foods. If it is lacking in real whole food ingredients, it is not considered a blended tube feeding product. Using commercial blended tube feeding in the hospital has benefits for both the hospital system and the patient. Commercial blended tube feeding products are convenient, ready-to-use products with known consistencies and nutritional value, and provide the benefits of real food tube feeding without the need for hospital resources to prepare blended tube feedings from scratch. Also, placing hospitalized patients on a commercial blended tube feeding product may decrease the risk of feeding intolerance and/or stooling problems that are often seen with standard commercial formulas. If the patient is discharging home on a tube feeding, a well-tolerated tube feeding regimen using a real food-based product could smooth the transition from hospital to home and even lead to improved health outcomes and quality of life. Now let's briefly review some indications for use of commercial blended tube feeding in the hospitalized patient. Practice recommendations from Aspen state that prior to blenderized tube feeding initiation and throughout the hospital stay, patients should be routinely assessed by a registered dietitian to determine clinical appropriateness and gastrointestinal stability, and for the absence of other contraindications or clinical changes affecting the ability to use blenderized tube feeding. Aspen practice recommendations also state that blended tube feeding is considered safe for stable ward patients who have previously demonstrated tolerance and those who can tolerate the hospital method of feeding. In my clinical experience, if a tube-fed patient has never had a commercial blended tube feeding product, a slower introduction and advancement could be beneficial for optimal tolerance. Aspen practice recommendations state commercial blended tube feeding is safe for hemodynamically stable patients in the ICU setting. However, lack of evidence and concerns about composition, for example, fiber types and amounts, as well as the ability to deliver commercial blenderized tube feeding exist. Lastly, Aspen practice recommendations state it is safe for immunocompromised patients, but paying extra attention to proper food safety principles and recommended hang times is warranted. Now let's talk about commercial blended tube feeding and enteral access devices. Overall, a gastrostomy tube is preferred. However, nasogastric or feeding into the intestine can be considered based on the patient's clinical status. Commercial blended tube feeding product manufacturers will make recommendations as to the French size needed, and even smaller French sizes can be used if good care and technique are implemented. Also, because of the increased viscosity of commercial blended tube feeding formulas, feeding times and/or force required to give them may be increased. In my clinical experience, tube clogging with commercial blenderized tube feeding products is rare, but it can happen, and it is important to understand why. The size of the enteral access device certainly plays a role, which is why it's important to follow manufacturers' recommendations for French size. Also, the particle size and temperature of the formula can impact clogging. For example, if the formula is too cold, it is likely thicker viscosity and not as well blended and could increase the risk of clogging. Lastly, proper flushing techniques should be reviewed with patients to decrease the risk of clogs. I'd like to now turn our attention to briefly review how to get commercial blended tube feeding products on a hospital enteral nutrition formulary. First, it is important to organize a multidisciplinary team that not only includes a registered dietitian, but any provider that will touch commercial blended tube feeding products in any way. This team should review the literature on blended tube feeding and do an in-depth review of their commercial blended products that they are interested in. No commercial blended tube feeding products are the same, and hang times, nutrient provision, consistency, cost, ability to work with the current hospital feeding methods are just a few important things to consider. In evaluating commercial blended tube feeding products, it is also important to check to see if the current hospital formulary contract has an option for a commercial blended product already. Once a decision has been made on what commercial blended tube feeding product or products will be carried, protocols and policies for everything from appropriate patient selection to administration should be developed. Lastly, in-depth staff education and training should be implemented, ensuring that any staff who will be involved with these products in any way be involved. Lastly, providing patient education on tube feeding is part of high-quality care. However, special education as to the use of a commercial blended tube feeding product may be warranted, especially if the patient is to be discharged home on the product.
Hello everyone, my name is April Church and I will continue the discussion on the use of commercial blended tube feeding in the hospitalized patient. Let's talk about transitioning tips. You first want to have a dietitian or clinician assessment. Is the patient suitable for CBTF? Are they currently tolerating their EN formula? And what are the patient preferences, goals, and desired outcomes? The other thing you want to consider is, are we transitioning from a fiber to a non-fiber formula or vice versa? And do we need to consider the need for disease-specific or hydrolyzed formulas? Tolerance of the CBTF regimen. You always want to consider the volume administered and gastrointestinal symptoms that may occur. Patients with altered GI tracts or absorption may actually require more attention to ensure continued tolerance. You also want to closely monitor your patients on CBTF. This can help reduce incidence of complications such as abnormalities, tolerance issues, or inadequacies. You want to follow institution-specific policies and procedures for frequency of EN order review and dietitian follow-up to ensure safe and effective use prior to discharge. Monitoring CBTF in the hospitalized patient doesn't differ much from your general patients on enteral nutrition. Every 1 to 2 days, you want to review or monitor your critically ill adults and pediatric patients, any patients at risk for refeeding, post-surgical patients or patients with poor glycemic control, and any patients with abnormal or unstable fluid and electrolyte status. You can expand your monitoring every 2 to 7 days or 1 to 3 times per week in your stable critically ill adult patients and your stable acute care patients. Follow-up. You want to follow hospital protocols and policies for enteral nutrition follow-ups. You want to consider the volume administered, any fluid imbalances, the ability to transition from continuous to bolus, the nutritional status, labs, medication review, GI intolerance, and any mechanical issues that may arise. Things to consider in preparation for home. Has the patient established tolerance, and do they have a safe environment to go home to? You want to collaborate among all disciplines, from your case manager to the enteral supply company to physician, home care, dietitian, and most of all the patient and the caregiver. What are their goals and preferences? And how can we meet their needs? Now that we are ready for discharge, do we have everything in line for tube feeding coverage at home, including insurance and out-of-pocket cost considerations, the HCPCS code, which is the product identification for Medicare, Medicaid, and third-party insurance reimbursement, as well as dietitian and/or medical provider documentation. One of the most important steps prior to discharge is patient and caregiver education. You want to provide both written and verbal education and assess the competency of the patient and caregiver utilizing the teach-back method. You also want to make sure that you've touched base on the following: the enteral formula, how to safely prepare and administer, the feeding device route and method, hydration considerations, medication considerations, how to safely clean and use the equipment, how to manage complications and shortages, and make sure you've scheduled a follow-up for a weight check and lab work. Additional topics to inform patients on before going home. Patients and caregivers need to realize that specific CBTFs may not be available at all institutions, for example, if you're being discharged to a nursing home. And you're also dependent upon the individual hospital or supplier's formulary. So if you are readmitted to a hospital, you may have to accept a substitute or bring in your own home commercial BTF. And patients who are on home-prepared blended tube feedings may also need to transition to a commercially prepared BTF in the hospital if available, or a standard formula. Now, this may cause undue stress and anxiety to patients when they're readmitted to the hospital, but more and more hospitals are developing policies and procedures to provide in-house blended formulas to meet the needs of the special population. Now let's look at a case study. A nutrition consult was placed for a 7-year-old boy admitted with influenza A. His past medical history included prematurity, single ventricle defect, and protein-losing enteropathy. He is prone to diarrhea, and he was also EN dependent with minimal intakes by mouth for pleasure feedings only. The boy's height was 120 centimeters. His weight was 18.5 kilograms. The dietitian estimated his caloric needs at 1,550 calories, his protein needs at 3 to 4 grams per kilogram, or 56 to 75 grams per day. Upon evaluation of the home enteral formula, the boy was receiving an organic pediatric peptide pea protein food ingredient 1.0 cal formula. He had a unique bolus regimen of 250 ml carton of the pediatric pea protein formula thinned with 100 mLs of a clear liquid nutrition drink 5 times daily. After each bolus, they flushed 30 to 60 mLs of water. This delivered 1,750 calories, 65 grams of protein, 10 grams of fiber, and 1,585 mLs of free water. We now arrive at the hospital enteral nutrition order. An inpatient dietitian familiar with CBTF collaborated with the mother as the hospital did not carry the patient's home formula, nor was the hospital policy in line with diluting a formula with a clear liquid supplement. So, a mutual agreement was made to use the hospital equivalent available formula and not dilute the clear liquid supplement during the hospital stay. The home regimen also provided more calories than the estimated needs of the dietitian. And one thing I want to point out here is when working with commercial blenderized tube feeding patients, sometimes our clinical judgment needs to really work in line with what works for the patient and their preferences. They always say mom knows best and that they know these kiddos, or the caregiver knows the adult patient in and out. They know what works and what they've tolerated. So sometimes even if the regimen seems a bit off, as long as it's meeting the nutrition needs, macro and micronutrients of the patients, it is best to continue with the home regimen or as close to the home regimen as possible. The hospital order ended up being for this patient an organic pediatric peptide formula made with pea protein at 1.0 cal per ml. Bolus regimen was 350 mLs 5 times daily. Water flush was still 30 to 60 mLs after each bolus. The nutritional delivery was equivalent to the home regimen as it provided 1,750 calories, 63 grams of protein, 21 grams of fiber, and 1,532 mLs of free water. About the only difference between the two regimens was that the fiber content went from 10 grams of fiber to 21 grams of fiber. And in this case, as a clinician, I would just monitor his gastrointestinal tolerance, his stool frequencies, along with other, gastrointestinal symptoms and hydration. And again, like I said earlier, one of the most important things is try to stick, if you're not able to provide their home formula, to stick to as close of a regimen as you can as their home regimen.
And here are the references. This educational offering was provided to you by Aspen. It was co-sponsored by Functional Formularies and Real Food Blends. Real Food Blends is part of the Nutrition North America family of brands.